Hello, everyone. So I think a few more participants will be joining, but it's 1 minute past the hour. So I may just have some housekeeping slides so that we can start the webinar slowly and when we are waiting for more participants to join. So I'm Karine Yang from the WHO headquarters, Department of Immunization, Vaccines and Biologicals. Thanks very much for joining the 14th session of this series of webinar on the COVID-19 vaccine costing, budgeting, financing and delivery. Today's topic is COVID-19 vaccination financing in the Southeast Asia region. And let's go to the next slide for some housekeeping items. Next slide, please. Okay, so we are offering an interpretation today in both French and Spanish. You can access that by clicking the globe icon at the bottom right of the Zoom toolbar and selecting the language that you would like to hear. If you only want to hear the interpreted language and not the original language in the background, click on the Mute Original Audio button. Next. We are looking forward to all your questions and comments. Please place any technical questions in the Q&A feature, which is just to the left of the CC icon. And if you have any logistical or IT questions, please put that in the chat and the ECHO team will help out. Next slide. We are offering a live transcript, which is only in English. If you are interested in seeing that, click on the icon in between the Q&A and interpretation icons and choose Show Subtitle, and the captions will appear on the screen. To close that, just click Hide Subtitle. Next. Just some notes for the recordings and certificates of attendance. This session is being recorded and your attendance is consented to be recorded. Thanks for that. And the recordings in English, French, and Spanish will all be shared afterwards through a follow-up email as well as on the TechNet21 website. The link will be shared in the chat. The certificates of attendance will be available through the University of New Mexico, where Project ECHO is based. They will share a link to that in the chat about 15 minutes before the end of today's session. And there will be a brief survey that should take around 3 to 4 minutes to complete. And your feedback will be very useful for internal quality improvement, and you will obtain the certificate after completing the survey. Next. A note about data use. The data collected is taken very seriously, and the data you provided will be all aggregated and de-identified before sharing with WHO. Next. Okay, let's start today's webinar with some announcements from the department. Next. WHO issued an emergency use listing for the vaccine validated for the prevention of COVID-19, COVAXIN. You can find more details of the vaccines and the SAGE interim recommendations through the links here. And second, there is a new publication on the joint WHO-UNICEF path guidance on selecting, commissioning, and using freeze preventative vaccine carriers. And the English version is available. Next slide. Okay, today is the last session in November. We will have a break after today. And the next session will be on the 1st of December on the country, regional and global views on COVID-19 and COVAX data. Then we will have a session on COVID-19 vaccines impact modeling, and the end of the series will be on the global status update. Next. Okay, for today, we are glad to have the sharing by the Southeast Asia region on COVID-19 financing. We will first have the opening remarks by Valeria. Dr. Valeria will have opening remarks, and then we will have 3 presentations moderated by Dr. Somo. And the 3 presentations will be about COVID-19 and health financing, COVID-19 vaccination landscapes on costing conceptualization, and public financial management, and finally experience in Bhutan. And before handing over to Valeria, I would like to have some pool questions with you all. And can Echo Team please open up the pool? And you can see here, I have 3 questions that we would like to understand from you. And you can scroll down to see all 3 questions. Okay, so the first questions, in which WHO region do you work? African region, Eastern Mediterranean region, European region, the Americas, Western Pacific region, or Southeast Asia region? Second questions, what was your involvement in the development of the NDVP, the National Deployment and Vaccination Plan for COVID-19 in the country? So you can choose participated with the costing and funding session, participated with other sessions of the plan, external advisor for the costing and funding session, external advisor for other sessions of the plan, did not participate in the elaboration of the plan but know of it, did not participate in the elaboration of the plan but not aware of that. And the final questions, what is the main challenge your country faced with COVID-19 vaccine financing? You can choose more than one answers. First, lack of sufficient public resources. Second, awareness and commitment by policymakers. Third, poor coordination across institutions. And finally, others. If you have other questions, please kindly type in the chat. And we really hope that to understand more about the challenges in the countries and see how the regional office or headquarters can help. So please answer the questions. And if we have enough response, the ECHO team can also pull up the result. Okay. Yeah, so you can choose the answer in the pool. And then for the final question, if you have other challenges, you can also type in the chat. So if we have enough in response, and ECHO team, please pull up the result. Okay, good. So for the region, yeah, that's very good. We have more than 50% from the Southeast Asia region. Then today you will hear more about your region. And then for the second questions, for the your involvement in the NDVP. So most of you participate in the NDVP development, and 25% will be on costing and funding. And then for the challenges, okay, so more than half things that the poor coordination across institutions. Yeah, good to know that. And then around 1/3 will be the other 2. And good that if we can have more insight of the others challenges, because 25% of you think you have other challenges, please put in the chat that we can understand more. When we go through the next slides, you can still type in your challenges, and be happy to document and see how best to support. And thanks a lot for your participations in the pool. Next slide. And without further ado, my pleasure to hand over to the microphone to Valeria to say a few words. Valeria is the Regional Advisor in Health Financing and Governance of WHO Regional Office for Southeast Asia. Valeria, please.
Thank you very much, Karine, and good morning, good afternoon, good evening to all of you. It is a great pleasure to welcome you to our webinar today on the COVID-19 vaccine financing in the Southeast Asia region. This is a WHO region comprising 11 countries with over 1/4 of the world's population. And having been able to develop effective and safe vaccines in such a record time, it was a major scientific achievement for the international community. Now, rolling this vaccine out and sustaining it requires a number of prerequisites. And a critical one, of course, is the financing. And here, I mean, not only the necessary financial resources, but also effective mechanisms that enables these financial resources to be implemented all the way down to the local level, and ensures vaccines reach people's arms and that no one is left behind. And in light of the double shock the world has experienced, the health and economic crisis, resources to maintain essential health services, to respond to the needs of the pandemic, and to finance the vaccine programs have become even more scarce. So we therefore need not only to sustain, but to increase health spending in order to not reverse gains made in the past, and also to address the demands of the pandemic, including the vaccination programs. And at the same time, we need to seek ways to spend resources more efficiently, but at the same time also protect the poor and the vulnerable. And in this context, our goal today through this webinar is to provide key policy insights for policymakers, but also to practitioners towards successful and sustainable COVID vaccine financing programs across the region. Our learning objectives today is first, to raise awareness about economic and budgetary implications of COVID-19, especially on health financing in the Southeast Asia region. Secondly, is to share findings of a landscaping analysis on COVID vaccine financing in the Southeast Asia region, which is the first one that has been done in our region, and we hope to continue this work in the future. And thirdly, importantly, it is that we share good practices, challenges, and lessons from the field. And today, more specifically, we hear the lessons from Bhutan, which has done remarkably well. And we're really looking forward to hear more how this country in our region has gone through the pandemic, the crisis, and how it is rolling out its vaccination program and what lessons it will share with us. And with these initial words, I thank you all, and I look forward to a very exciting session with you. And I now hand over to my colleague, Solomon Sisilaja. Thank you.
Thank you. Thank you, Valeria. So good morning, good afternoon, and good evening to you where you are connecting from. Yes, so to achieve today's objectives shared by Valeria just now, we have three excellent speakers. And I will further provide an introduction of each speaker before each presentation. But first, we will have Ajay Tandon from the World Bank, who will be talking about impacts of COVID-19 to health financing. And then Dr. Wei Aoun, the consultant with us, will be providing specific context and details about the regional situation as to the COVID-19 vaccination financing issues in this region. Thirdly, we will be listening to Sangay Phuntsho from the Ministry of Health in Bhutan to do deep dive into experiences in Bhutan and so on. So, and hope you will enjoy tuning into these informative presentations. So without further ado, let's start with the content of this webinar. Yeah, so my first speaker is Ajay Tandon, as I said, from World Bank, and Ajay is the lead economist in the World Bank's global practice on health, nutrition, and population. He works on several countries, including most recently on India, Indonesia, Bhutan, and Laos PDR. He received a PhD in economics from Virginia Tech. Previously, Ajay worked with Asian Development Bank and the World Health Organization. He has had visiting research appointments at both Oxford University and Harvard University. He has written multiple publications on the issues of statistical methodology, health systems efficiency, health financing, fiscal space for health, health taxes, and the universal health coverage. So over to you, Ajay. Just a reminder to everyone that please do send your questions and clarifications to the Q&A box by clicking on the Q&A icon. Thanks. Over to you, Ajay.
Thank you, Solomon, for those kind words of introduction, and also to Valeria. There was a comment earlier that the sound quality is not very good. So in case it is not good, if somebody can flag on the chat again. So as Valeria mentioned, I think one of the points also that is emerging is in the CRO region, the Southeast Asia Regional Office region of the WHO. There are also these stark, inequalities that are emerging in terms of vaccine coverage. So on the one hand, you have countries like Sri Lanka and Bhutan, from whom we'll hear a little bit later, and also Thailand, where the vaccine coverage rates have really rapidly improved and are sort of leading the way. But on the other hand, we also have countries like Myanmar and Nepal and Bangladesh that are lagging behind. So, you know, in some cases, these are not necessarily challenges related to financing alone. There are issues related to supply of vaccines, delivery, logistics. But anyway, in this presentation, I just want to give you an overview of really the economic impact of COVID-19. We all know that you know COVID-19 has had a health impact in terms of mortality, in terms of morbidity, hospitalization, and so on and so forth. But the focus here is on financing and really what has been the impact of COVID-19 on ability to finance things, in particular health, as well as including vaccines and including the possibility in the future, although uncertain, about booster doses, etc. So next slide, please. So we at the World Bank have you know, there's a working paper called From Double Shocks to Double Recovery. The point, I think, as Valeria mentioned, is to recognize the fact that COVID-19 was a double shock. So economists, when they say shock, they mean an adverse precipitated event. So a double shock meaning it was both a health shock, but it's also been a massive economic shock. And the double recovery refers to the fact that it's really something that happened in health that caused this shock, but it's really something that needs to happen in health that will get us out of this shock. And we won't have a sustained economic recovery unless and until vaccination rates go up and also the other sort of non-pharmaceutical interventions are sustained. Both in the short term, but also more in the longer term. So there's going to be no sustained economic recovery from this pandemic without a recovery in health, in the health sector. So we need to end the pandemic. We want to also prevent future health crises. And we also want to regain losses in universal health coverage that have occurred as a result of COVID-19. So that's sort of the use of the terminology double shocks to double recovery. That's where it's coming from. Next slide, please. So basically, I'll just give a sort of a summary of this paper. It's available online. There's a link to it on the presentation itself, but if people are interested, we can share also in the chat. So I'll just briefly give you a flavor of what's been the macro fiscal impact. By macro fiscal, I mean what's been the impact on the macroeconomy of countries, as well as a fiscal, meaning what's been the impact on the government sector, on government taxes and revenues and government spending, and potentially discuss what could be health spending consequences. Not so much in 2020, where we know that there was a lot of emergency health spending, but really in 2021, 2022, and in the medium term, what the implications could be and what are the implications for the double recovery. Next slide, please. So let's start with the macroeconomic impact. The next slide. So I assume this is common knowledge to all, but just worth looking again at this graph. This shows you what's been the percentage increase in economic activity, economic growth, basically, in CRO countries from 2000 to 2026. And I've also highlighted the last sort of big crisis that happened in the world. This was in around 2007, 2008. It's called the global financial crisis. As you can see, there was a slowdown in economic growth for the global financial crisis, but it didn't go below zero. We still had average economic growth around 3% in per capita terms across CRO countries. But really, the situation this time has been very different. This economic crisis resulting from COVID has led to an average contraction in the economies of more than 6% across CRO countries. So it's actually 6.4% contraction. And at current trends, we're still not completely sure, but if you take a look at the latest forecast from the IMF, the projections are that we will see positive economic growth in 2021 of about 3.2%, but that's subject to still tremendous uncertainty, and we don't quite know what's going to happen. And the other key point is that the region on average will return to pre-COVID levels of GDP only in 2023. So it's not just that the shock happened in 2020, but there's going to be a longer term impact because now the economies are growing from a lower level, but it'll take them several years to get back to pre-pandemic levels of economic activity. So that's one key takeaway message about the scarring, economic scarring from COVID-19. Next slide, please. The other point is that the COVID-19's economic impact has also affected government revenues and also led to large increases in government borrowing. So what I'm showing over here is that in terms of CRO countries, the per capita general government expenditure, meaning the ability of the government to finance all sectors, including health, is by 2026. I mean, it's many of the countries, the ones that are listed on the left-hand side graphic, show that government spending actually went up as we might have expected, despite a decline in revenues because of greater borrowing from the government. And by the time in these countries, by the time we get to 2026, we do expect government size to be bigger in the same way that it has been in the past. But there are a couple of countries in CRO, in particular Maldives and Timor-Leste, where even in 2026, we are expecting or projecting the size of the government to actually become lower than it was in 2019, and a lot of sort of uncertainty around the levels of per capita government spending in those countries. Next slide. So really, so what's the important of? So let's now focus attention really on public on financing for health, and sort of the circular graphic on the left-hand side shows you the different ways in which health systems are financed. Typically, you have these 6 big buckets. Health systems can be financed through government borrowing, including government revenues, including borrowing. In some cases, external financing, either through the government budget or directly to NGOs. You also have some countries, in particular Indonesia, where social health insurance is a source of financing for the health system. Basically, social health insurance is a mandatory earmarked income tax, actually a wage payroll tax. I also think there is a small amount of payroll tax, and our speaker from Bhutan can confirm that also contributes to the health trust fund in Bhutan. You have also private health insurance. It's not a big source of financing, but of course, out-of-pocket spending and also other sources of financing. On the right-hand side, you actually see what are the levels and composition of where is the money coming from. So huge diversity in CRO countries. So you have Maldives, where total health spending per capita is around $1,000 just before COVID. Thailand is just above $250. India is about $70. Bangladesh is about $40. And of course, big differences in how this is financed. So you can see that Maldives and Thailand, for instance, the orange part is big. So that means a large source of the financing for the health sector there comes from the government. Social health insurance is really only a big issue in Indonesia, to a smaller extent in Thailand. But really, in many countries in the CRO region, it's really out-of-pocket spending that dominates the health financing landscape and dominated the health financing landscape. And I think one key takeaway message is that how you finance your health system also has implications for how you would want to finance vaccines. So actually, characteristics of vaccines are such that you would want to actually use government revenues, public financing, domestically sourced or externally sourced, to finance the COVID-19 vaccine. Social health insurance is not the best way to finance vaccine coverage. Not everybody has social health insurance. And also as a result of the macroeconomic shock from COVID, unemployment has gone up, employment rates have gone down, wages have gone down. So it's not sort of a good source of financing, and private health insurance in general is tiny in the region as well as globally. And you actually don't want vaccine financing to come from out-of-pocket sources. Because you want to remove any barriers that might be. You may want to have out-of-pocket financing for the rich and allow them to get that, but really that shouldn't be sort of part of government policy. It should be freely provided and made as easy to access as possible. Next slide. So one point to take away is that the flip side of how the health systems are financed in CRO countries is that the reason there's so much out-of-pocket financing in many countries in CRO, including in Bangladesh, Nepal, in India, in Myanmar, also in Indonesia, that these are the dominant source of financing is out-of-pocket. And the reason out-of-pocket spending is so high in these countries is because the government financing is low. So whenever government financing is low, you end up in a situation where out-of-pocket financing is high. And what this is showing you on the left-hand side is really, not only is it low, but most of the growth in public financing that's happened in the past 10 years or so, a large part of it has come from economic growth. So it's showing you there's been some increase, but even despite this increase, if you take an example, for instance, in the case of India, in 2009, government spending per capita was only $11 in India, and it increased to $20. But that increase really was because economic growth was happening. That's showing you the green dot over there. That the source of growth in public financing for health came from the growing size of the economy, not because health was getting a bigger share of the government budget. And anyway, people who are interested in understanding, the decomposition of, how you look at growth in public spending for health and where it comes from, you can contact me afterwards, and I can give you links to a paper that explains a bit more. But one thing is to really look at why is public financing for health low in countries, and in many cases it's because the share that health gets in government budgets is low. But in some other countries, it's also a problem of the share of revenues that are collected, the public revenues in the economy. For instance, in Bangladesh and Sri Lanka, revenue collection overall to be able to finance all sectors is very low. It's only about 10% of GDP. And that is also a constraint to be able to finance health from government coffers. Next slide. So just to speculate a little bit in terms of the COVID-19 health spending impact, and in particular the government spending impact. Next slide, because that's what we want to see. There are sort of multiple pathways of government spending on health. So in some cases, if for instance, we've looked at different scenarios that if health's share of the government budget doesn't increase, what might happen? Or if the health spending, government health spending continues to grow at the trend that it was continuing to grow in the past, what might happen? So we just looked at different scenarios to see potentially what could happen. I mean, there is a choice variable here. I think that's a key point to keep in mind, that the amount health gets out of a government budget is a choice, is a policy choice variable. Yeah, so that can be potentially adjusted to try and mitigate the impact, the negative impact, the macro fiscal stress on public financing for health. So next slide, please. And here, we are projecting that, for instance, if there's no proactive efforts to try and increase the sort of health share of the government budget, you're going to see a decline or potential uncertainty in terms of volatility in terms of per capita government spending on health that can occur as a result of the macro fiscal uncertainty that's projected to happen across CRO countries. And this is not unique to scenario. This is the CRO. This is happening almost all over the world, across all sorts of countries, low income, lower middle, upper middle income countries. Next slide, please. And really, on average, if we take a look at this, it's just showing you what's the average share of the government budget that goes to health in CRO countries. It's about 7.6%, one of the lowest in the world, and this would need to increase over time to about 11.3% of the government budget if, for instance, we want to protect the health sector from the macroeconomic shock that's occurring as a result of COVID-19. So again, the takeaway message here is that proactive efforts need to be made to make sure that the public spending on health envelope is protected in countries from all these shocks that are occurring to the economy. Next slide. And just finally, to talk a little bit about implications for a health recovery in lower and especially in lower and lower middle income countries more generally, but in particular in CRO. Next slide, please. So the expected, I think that the key point is that in addition to this tighter macro fiscal environment, that the spending needs have increased because earlier on we didn't have the COVID-19 vaccine that needed to be financed, and also you need to also account for the fact that you want to invest in also building much more resilience into the health system. And again, the point is that business as usual is not going to work. So there's need to be much more tweaking of the health budget, and it increases in other needs like pandemic preparedness and vaccine shouldn't come at the expense of lowering spending on routine health services, because already in many CRO countries those routine health services were underfinanced by the government. So in addition to that, the needs have gone up. So those challenges are facing several of our countries. Next slide. And really, we don't want to leave countries with this sort of either or toxic choices that whether you want to end the pandemic or you want to prevent the health crisis or you want to reclaim, you need to be able to do all of these. Otherwise, there's going to be a threat to sustained economic recovery. So you shouldn't sort of increase vaccine financing at the expense of sort of universal health coverage and routine health services. And same thing in terms of pandemic preparedness. You don't want to sort of take away routine financing and put it only towards a vertical program that looks at pandemic preparedness. Next slide, please. And really to end that, in some cases, you actually may also need to ramp up development assistance for health. There are several countries in the CRO region where this is very important. Nepal, to some extent Bangladesh, to a lesser extent Bhutan. And really, this is also the time for higher income countries to also step up development assistance for health. The time for action is now. There was a multilateral leaders task force on COVID-19, and really, the course of the pandemic and the health of the world are at stake. So the important point is to come together and not just view this from a very limited myopic point of view, but to also not only look at what's happening in your own countries, but also what's happening broader in the region as well as globally, because we need to end the crisis everywhere for us to really get back to some semblance of business as usual. So I think I'll end here and hand it back to Salman.
Yes. Thank you, Ajay, for this very informative and also same time thought-provoking presentation. Indeed, thinking about these macroeconomic and health financing challenges impacted by COVID, we in the health system policymaking and planning should really remain proactive, as you said rightly, and be attentive about the health financing challenges and needs that is coming from COVID-19. So let's spend some minutes, 5 minutes, taking questions and clarifications on your presentation. So the participants can press the Q&A icon and type in your questions and clarifications. So we already have two questions already typed in. So I think it's one is for Valeria and other one is for Ajay. One is so how many are there any AMC countries in Southeast Asia region? I think that's one question to Valeria. And the second is to Ajay. How the World Bank is categorizing the countries for financial support according to economic status of the state for COVID-19 in the region. So, so maybe you want to take a mic and switch on your mic and answer it live.
Okay, maybe I can get started. So the bank, categorizes countries whether they're low income, lower middle income, upper middle income, and high income. Low income countries generally are countries where your per capita income is less than $1,000 per capita. Lower middle income countries are those, roughly speaking, where the per capita income is between $1,000 and $4,000 per capita. Upper middle countries are between 4,000 and 12,000, and high income are between 12,000 and above. So CRO region is largely a lower middle income region. So even sort of Bangladesh, India, Nepal, Myanmar are lower middle income countries. They are in the $1,000 to $4,000 per capita sort of thing. So Indonesia, as a result of the economic crisis, Indonesia was upper middle income. I believe it's been reclassified as lower middle income. And of course, you have Thailand, and I think Sri Lanka is also now lower middle income. And I think Bhutan is upper middle. But again, these categories can matter. So in terms of how financing is prioritized, and also although there's not a one-to-one mapping from low income, lower middle, and upper middle income, but there's also if you're low income or if there are some other stressors that you're facing, you also qualify for concessionary financing, which is called IDA, International Development Assistance. And so and there's another question, but I'll just answer that development assistance for health and has been important in some countries in CRO, not so important in countries like India. It's not that important in Indonesia, definitely not at all in Thailand. But there are some countries in the region that are quite dependent on development assistance for health, as you might expect. For instance, Nepal, to some lesser extent, Bangladesh, Bhutan, where there are concerns that because of the macroeconomic shock as a result of COVID-19 has affected all classes of countries, not just poorer countries. Even the richer countries have been affected. That potentially can affect development assistance for health. And in many countries, we've seen not a decline as expected in development assistance for health, but what has happened is there's been an increase in borrowing generally from the market or from the central bank. So the deficits went up and debt levels have increased significantly, not just in CRO, but in many other countries for the world, which is to be expected. You actually want governments to borrow during times of crisis so that to mitigate the impact of the crisis. But I think the other key point that one should take away is, as a result of that increase in debt and deficit, debt servicing has gone up in the region. So, for instance, Sri Lanka already had very high debt servicing as a share of the government spending. It's, I think, gone up even higher. So, as many countries in the region, the debt servicing as a share of the government budget is actually higher than the amount that goes towards health. So, there can be these indirect effects that might help squeeze or worsen the situation for our sector. And I think the key point is vigilance and to try and make sure that at least at this critical juncture, cuts shouldn't be happening in the health sector. That's sort of the wrong thing to do. If there are other sectors, I mean, you can delay capital spending in the sectors, or you can find things like fuel subsidies or other unproductive sources of financing that could potentially be cut. But also you can try to increase revenues by using health taxes. This might be a very good time to relook at some of those things that traditionally industries will try to go against. I'm talking about tobacco taxes, alcohol taxes, taxes on sugar sweetened beverages, also debt relief tied to additional financing for health. So a lot of options at the table. The key is to be aware of what's happening and how that might impact financing for the health sector, and to also try to get a census and learn from what other countries might be doing in terms of trying to mitigate the impact and sharing of lessons across all. I'll hand it over to Valeria. Thanks.
Valeria, would you like to answer live or type in?
Thank you. Thank you. Yeah, no, I really don't have much to add after the rich answers from Ajay. Just on the AMC countries, since at the moment, as we know, I mean, income classification is dynamic, and countries can be in and out of a certain classification as crisis hit. So majority of our countries are now on the lower income bracket, and so therefore a lot of them fall under the AMC COVAX. But even some like the Maldives, which is not a lower and middle income country, does receive additional IDA. So they are eligible for additional ADA. So just wanted to add that. Thank you. Over to Salman.
Thank you. Thank you for these answers. So once again, thank you, Ajay and Valeria, for reminding us about the seriousness of the issue and the additional health financing policy options to widen up the fiscal space to mitigate the impacts of COVID-19. So let's move to our second presentation. This second presentation is about the findings of our work that we did to examine how the countries in the Southeast Asia region work to address some of the important institutional and technical issues related to the unprecedented tasks of vaccine financing. And this will be presented by Dr. Wei Aun. Wei Aun worked as a medical doctor in Malaysia and the UK before transitioning to the public health. So he consults for World Health Organization and also for the World Bank on health systems and health financing issues. And currently Wei Aun is working on the COVID-19 vaccination costing and financing with us in this region. Thank you. Wei Aun, over to you.
Thank you very much. Good morning, good afternoon, and good evening. I'll be presenting the findings of a landscaping exercise of COVID-19 vaccine financing, covering cost estimations placed in context, as well as public financial management. And this is based on a rapid data collection exercise, which provides a broad landscape, but unfortunately not an exhaustive country-level deep dive. And I would like to acknowledge the in-country consultants and country-level stakeholders who have provided the information basis underpinning this analysis. The analysis is not finalized and may be subject to further changes. Next slide, please. There are 4 sections in this presentation. The first summarizes cost estimates actually done by member states themselves. So this is from NVDPs and country-specific costing exercises. And it's only when these were unavailable was the global costing estimate used. The second section really asks the question, what do these cost estimates mean? Are they affordable? Can the health sector absorb it? And this is what the second section discusses. Many member states have made progress in funding their vaccination plans from domestic and/or external sources. And to the extent that these are disclosed, I'll describe them in section 3. But importantly, as alluded by Ajay already, even with vaccine doses and financing, countries still face challenges executing their plans, as Public Financial Management, or PFM, been adequate to allow for realistic planning to distribute resources and optimize delivery strategies? Have disbursements to frontline providers been adequate? Has the emergency procurement of critical commodities been fit for purpose? Has it been efficient? These are the kind of PFM considerations described in the final section. The first section, next slide, please, is on estimated costs. Next slide, please. There was a 15-fold difference between the lowest and highest vaccination delivery costs per fully immunized person. These exclude vaccine procurement. Noting the limitations of making inferences from a small sample of member states, the variation in costs appear observationally to be driven by a few issues. The first is the content of what was costed. States with strong health systems generally did not have to include so many cost items, as these were presumably able to leverage existing capacity, whereas countries with weak pre-existing health systems costed in large surge costs, particularly for human resources. So said differently, member states which had already invested in strong health systems faced less incremental costs to deliver critical interventions in an emergency. The second driver is the methods used. A variety of methodologies were used, but most actually based their estimates on existing immunization or EPI plans. But these cover quite a different target group and generally occur during regular delivery of MCH services. Furthermore, the speed and scale is on a different magnitude altogether. The CR region is a diverse region with some of the most populous member states in the world, which are on the left, but also some very small member states, which are on the right. Economies of scale did not actually appear, though, to drive the differences in costs, as seen from the chart shown. Next slide, please. Based on disclosed transactions, there was a 4-fold difference in the price paid for a vaccine cost of typically 2 doses. The analysis excludes donations and non-government, i.e. private supply, and vaccine procurement costs are where possible based on matched disclosed transactions. So where it's actually published, it's actually based on real transaction data or the closest disclosed transactions. So although there was a small variation in the disclosed transacted price for a single vaccine type, so like with just like a vaccine like Covaxin, for example, may have different in prices, but the vast majority of price differences were actually driven by the choice of vaccine. Now, this may be actually stating the obvious, but vaccines vary a lot in prices, and countries which chose to procure expensive vaccines obviously paid significantly more. Importantly, though, paying for expensive vaccines did not appear to be related for faster vaccine access, nor higher vaccine efficacy. The fastest vaccinators in the region are Bhutan, which we'll hear about a lot more, which depended solely on donated vaccines, Maldives, Sri Lanka, and India. Apart from Sri Lanka, these countries are actually countries which paid quite low for vaccine supply. On the other hand, we have Bangladesh, which paid the highest unit price and is among the slowest to vaccinate its population. Economies of scale, cheaper prices for large orders also do not appear to explain the variation in prices. So this suggests to me that efficiency improvements in the overall procurement strategy and process can be made. Now, this is an important lesson to be explored further, not just for the remaining vaccine procurement for children and booster doses, but also for future pandemics. Next slide, please. But what do these costs mean to member states? How does it compare with key health sector and macroeconomic parameters such as domestic government health spending or GGHED, the size of the government, the size of the economy, and existing vaccination programs? Next slide, please. The analysis compares delivery costs excluding vaccine procurement with the size of domestic general government expenditure on health, or GGHED, as an imperfect proxy for the size of the public health system. This is to provide an indication of the footprint of COVID-19 vaccination within the public health system, including its absorptive capacity, the risk of displacing essential health services, and the feasibility of scale-up. This does not imply that financing for COVID-19 vaccination delivery should be reallocated from the health sector, as COVID-19 vaccinations allow a broader socio-economic reopening, even if it's going to be delivered via the health sector mainly. And I think Ajay has already stressed that point. In order to allow cross-country comparisons of the footprint, given that in NVDP plans, member states stated coverage plans actually range from 20% of the population all the way to 100% of the population. So I scaled down the delivery costs into two standardized scenarios, 20% coverage by 2021 and an additional 60% coverage in 2022. And the findings are as follows. The footprint of COVID-19 vaccinations using this metric ranges really from what I describe as the toe print of a net to an elephant's footprint. In many countries, it's just less than 1% of GGHED, for countries such as Bhutan, Maldives, and Thailand. But for Bangladesh, for example, it's almost 1/3. Well, sorry, it's more than 1/3 of GGHED. Unsurprisingly, Bhutan and Maldives are the fastest vaccinators in the region, and Bangladesh is among the slowest. The relative size of the footprint is driven particularly by the size of the pre-existing public health system as measured using GGHED and vaccination delivery costs, which as mentioned earlier, appear also related to pre-existing health systems capacity. Next slide, please. Total vaccination costs, which include vaccine procurement, are a critical health and socio-economic investment, and hence I'm contextualizing it against the broader economy and the size of the whole government, not just the health sector. Many Southeast Asia region member states have a pre-pandemic background of low government spending across all sectors, low government health spending and debt. There's also an ongoing and prolonged anti-pandemic economic crisis as explained by Ajay earlier in his presentation. When COVID-19 vaccination costs, the total cost, including vaccine procurement, are compared against GDP, total COVID-19 vaccination costs to cover 60% of the population is a fraction of 1% of GDP for all member states. This is, to me, a relatively modest amount considering the huge returns on investment as an economic stimulus. However, the size of government spending divided by GDP is low and variable across the region. COVID-19 vaccination costs to cover 60% of the population can be substantial for member states where the size of the government sector compared to GDP is modest. Hence, total COVID-19 vaccination costs is estimated to exceed 2% of general government expenditures across all sectors in 4 member states, Bangladesh, Indonesia, Myanmar, and Sri Lanka. The overall message to me from this is that considering how critical COVID-19 vaccinations are to reopen the economy, the cost of COVID-19 vaccination compared with GDP is modest, but when compared with the size of government spending, it is variable, reflecting modest government revenue collection and substantial debt servicing in many member states. Next slide, please. As I mentioned earlier, many member states base their cost estimates on existing vaccination programs. There's not much data available, but for a few member states where vaccination expenditures were available on the Global Health Expenditure Database, COVID-19 vaccination estimated costs eclipse routine immunization expenditures by some 1 or 2 orders of magnitude. Only in Bhutan, where the doses were essentially all donated and hence have no fiscal impact, was the size of the program comparable to existing vaccinations. It's also notable that for Bhutan, it's one of the fastest vaccinators, as we'll hear in the next presentation. Basing COVID-19 vaccination plans, strategies, and cost estimates on existing vaccination programs, in my opinion, would not be advisable. Next slide, please. There is some good news in the third section on the financing secured by member states. Now, this is a very fast-moving thing because countries are changing their financing plans quite fast. And so this analysis may not reflect the very latest updates. We also do not have enough time to discuss in detail, so I will just mention 2 headline messages from this section. Next slide, please. The first message is that in the last few months, most CR member states have made great strides in securing vaccine supply, and at least 5 member states have already disclosed vaccine supply arrangements which can cover greater than 100% of their population, including all age groups, with a full course of vaccines, excluding booster doses. But progress has been uneven, and some member states are far from securing adequate vaccine doses based on disclosed data. Next slide, please. The second headline message is that at least 3 member states, I think it's also good news, Bhutan, Maldives, and Nepal, have already disclosed financing commitments and disbursements, both domestic and external, which are estimated using this methodology as sufficient to cover at least 80% of the total population. For the remaining member states, this may reflect either a financing gap or a gap in disclosure. But the basic message is that widening disparities across member states in securing COVID-19 vaccination financing is hence a concern. And I also note the questions in the poll earlier asking about development assistance for health. Next slide, please. Which takes us to our last section, which is on PFM of public financial management, which is basically asking the question of how to ensure that resources reach frontline providers and enable vaccine delivery. And the framework that is used for this analysis is as cited in the slide. Before discussing this section, next slide, please. I would like to have a quick poll. We have 3 questions. So is it okay to bring up the poll? Let me read the 3 questions while waiting for the poll questions to come out. Have they come out? Okay, there we go. You may need to scroll down. There should be 3 questions that you can see. And if it doesn't fit in that window, you may need to scroll down to see all 3 questions. Let me read out these questions and I'll allow you to answer it as we go along. The first question is, has your country disclosed a budgetary commitment for COVID-19 vaccination in the coming fiscal year? And this is a yes/no question, but I'm most keen to actually hear your elaborations or to see your elaborations in the chat. So I would appreciate it if you would be able to do so. Just have it as a discussion. The next question is, has your country made tangible arrangements to integrate COVID-19 vaccination into the National Immunization Plan as part of routine service delivery? And there's also a yes and no question, but I really invite further discussion and elaboration in the chat so that we can have a parallel discussion. And the third question, remember you may need to scroll down, is what has your country done, if anything, to protect spending on essential health services during COVID-19 vaccination? And I think this is the most critical short-term issue facing COVID-19 vaccination, apart from just getting it out. I'll just pause a short while for people to discuss. And if you could use the chat to discuss this, that would be great as well. Next slide, please. Now, while people respond and hopefully participate in the chat, let me share a flavor of the PFM adaptations and innovations notable from this small and rapid data gathering exercise. Starting with the first part of the PFM cycle, which is budget planning and formulation. The question is, how did member states structure their COVID-19 vaccination budgets? Well, member states either did so within their existing budgetary systems or they used extra budgetary vehicles. For those which use existing systems, so these would include countries like Bhutan and Sri Lanka, many reported creating special budget lines, programs, or object codes, either very specifically for COVID-19 vaccination or more broadly for COVID-19 as a pandemic as a whole, treatment and not just the vaccination, and even more broadly, in the case of, let's say, I think Bhutan, for national level health emergencies in general. In the case of Sri Lanka, the use of the government budgeting system extended to external financing, and this is a point that was stressed by the consultant who was gathering the data on this. But some member states, such as Maldives, actually use extra budgetary vehicles, a special trust fund, for example, which would allow flexibility in procurement and fund transfers beyond the constraints of the regular budgeting system. Now, this does not mean that accountability needs to be compromised. These vehicles are generally subject to additional reporting requirements. We have to report more frequently, for example, and in the case of the Maldives, they actually have to publish it, I think every 2 weeks, the expenditure from these extra budgetary vehicles. Interestingly, the use or non-use of extra budgetary vehicles, so countries which chose to use existing systems or extra budgetary vehicles, was not particularly linked to performance. You can see that we have strong performing countries which chose one or the other of these two options. So I believe it's just linked to very specific country contexts. Next slide, please. For the next part of the PFM cycle, which is on budget execution and spending modalities, procurement of vaccine doses and related devices was really a critical area of adaptation, and almost all member states reported having to make some changes. These had a wide range of possibilities, and they range from just informal changes to practices, which were later formalized, or officially modified procurement rules. In the case of Sri Lanka, they introduced the COVID-19 emergency procurement process, and Maldives made an amendment to the public financial regulations. And countries such as Thailand went a bit further, and they established new institutions altogether to be responsible for guiding procurement. So it's the Center for COVID-19 Situation Administration in the case of Thailand. But changes to rules or institutional structure were not the only means to improve procurement processes. Maldives also just decided to bolster capacity by seconding a Ministry of Finance official in charge of procurement to the Ministry of Health so that bureaucratic processes could be done more smoothly. Next slide, please. How did member states expedite budget execution? Well, generally for COVID-19 vaccination, a lot of expenditures were centralized. Procurement of vaccine doses and related devices and logistical expenditures were all generally centrally incurred. So this reduced the burden on subnational spending units who would mainly be responsible for expenditures related to last mile delivery. To expedite that even more, a few additional strategies were employed by subnational entities. First, to get financing to these spending units, some countries forwarded allocations based on cost estimations. Some countries used temporary environment from other expense categories at the subnational level so that they could mobilize some financing immediately. And Bhutan, interestingly, used mobile technology. Maybe we can hear about that more in the next presentation, hopefully, to actually speed up the claims processes so that you could just have a constant replenishment of finances required by frontline providers. Next slide, please. Now, I presented these human resources for health related PFM innovations during just last week's ECHO session, which was recorded. So I'm not going to repeat it here. I'm not going to repeat the adaptations which are done to contract private sector and to maximize the use of public vaccinators in this slide. If you're interested, you can listen to last week's ECHO session. And next slide, please. Do allow me to conclude by mentioning some remaining gaps and opportunities. Now, although no member state reported intentionally trying to undermine existing essential health services while scaling up COVID-19 vaccinations, many implicitly reallocated budgets. So for example, and I won't name and shame, but for example, vaccination activities and vaccinator search costs were funded from funds from deferred activities related to essential health services. And in some cases, and I know Ajay alluded to this, funds were used from national health insurance schemes to pay for COVID-19 vaccination. Now, I guess to some extent, this is understandable given the emergency, but the question facing us is how can member states protect and revise spending on essential health services? And allow me to just make some suggestions. Firstly, I think it's important for countries to explicitly make adequately resourced plans to do so. Secondly, I think it's important to execute COVID-19 vaccination in as efficient a manner as possible and with as much budgetary predictability as feasible given uncertainties. And the subsequent bullets elaborate on this further. Thirdly, I think it's good at some point to start de-verticalizing from emergency expediencies, which keep things vertical for COVID-19 and COVID-19 vaccination, towards a more integrated approach to health, which includes COVID-19 and vaccinations. The second gap is cost estimations. And to me, there's an opportunity to review these comprehensively, not just in a perfunctory manner to fulfill a budget request, but with a view to optimize and minimize the resource impact. As hinted earlier, we saw a huge variation in vaccine delivery costs. The third gap is vaccine procurement. The choice of vaccine type is one of the largest drivers of total cost, so I think it's important for member states to choose wisely. Last slide, please. Next, yeah, okay. COVID-19 vaccination is not going to be a once-off activity. So securing financing for COVID-19 vaccination, in addition to essential health services to further UHC for subsequent fiscal years, is important. And ideally, this should be done in a manner as integrated as possible with national immunization plans. Finally, and most importantly, is a reminder, as we've seen from the earlier charts presented, member states which have been most successful at deploying this very critical economic stimulus to reopen their economies by rapid vaccinations have been those which have invested in public health and health systems. And those which have not have failed to reap the dividend and will face the economic repercussions, not to mention the health impacts of a delayed vaccination process. So if there's any single takeaway message from this, it is please invest in public health and health systems. With that, I thank you very much. The last slide's a thank you slide, I believe. And that's all from me.
Thank you, Bayon, for these very important and useful findings in this region. And it is interesting to see such a diverse practices, experience, and hope these will be learnings to others in vaccine financing policy making in the future. But before I don't think we have a Q&A, but maybe Bayon, you can wrap up the poll results of the earlier.
Yes, let's wrap up the poll results.
Yeah.
And can we display the results?
Yes, please. Yeah.
Okay. So has your country disclosed a budgetary commitment for COVID-19 vaccination the coming fiscal year? And just over half, or 54%, said yes. Has your country made tangible arrangements to integrate COVID-19 vaccination into the National Immunization Plan as part of routine service delivery? And again, just over half said yes. And let's see if anyone has shared any things that countries have done to protect spending on essential health services during COVID-19 vaccination in the chat. There's some elaboration from, well, I think we can all read the chat ourselves. Yeah. Really, thank you very much for those responses. Back to you, Salmon.
Thanks, Bayon, once again, for this insightful presentation and vaccination financing achievement challenges and gaps in this region. Okay, let's move to our third and final presentation. It's about the Bhutan experience, and Bhutan is one of the countries in the region demonstrated very good results in terms of COVID-19 response, and also in particular the vaccination deployment and coverage. And I'm sure there are policy implementation nuances and other factors and challenges that everyone can listen to and learn from Bhutan. And we have Mr. Sange Punso from the Ministry of Health. Sange is the Senior Program Officer in the Vaccine Preventable Disease Program of the Department of Public Health in the Ministry of Health, Bhutan. And Sange has a bachelor degree in science and master degree in public management. He's also a U.S. Fulbright Hubert Humphrey Fellow for Public Health Policy and Management. So Sange has been with the immunization program for more than a decade, and Sange really has been spearheading the COVID-19 vaccination program in Bhutan since the start of this program. So over to you, Sange. Thank you.
Thank you very much. Am I audible?
Yes, we can hear you loud and clear. Okay.
Thank you very much. Thank you for giving this opportunity to share our small experience in the global platform. Before I go with my presentation, I would like to quickly respond to what the previous two speakers have mentioned on, before I forget. on the health contributions for Bhutan, what Mr. Ajay has mentioned. For Bhutan, all the civil servants contribute 1% of their salary as health contributions to the government. And that is directly transferred to the Bhutan Health Trust Fund, which is funding the vaccine and essential medicines. When it comes to online payment, what Mr. Wei An has mentioned, we have developed recently. The Ministry of Finance of Bhutan has made an online payment system, and then that has actually helped us immediately make the payments, as well as to reduce the double claims or overlapping dates, especially for the per diem and all other government travels and payments. So these are some of the small things beyond the immunization, but government as a whole, as a holistic approach has been taken care in the country. So now going to the experience in Bhutan, I will be basically sharing how we have conducted the vaccination program, COVID-19 vaccination program in the country, and then what is our coverage as of now, and then because this has a direct implication to the financial and then the budgeting that we are discussing right now. So next slide, please. This is in brief, we would like to describe how vaccination program planning and implementation has been done in Bhutan. So our preparation has been a long time ago, since in early 2019, when we had the information of the virus. The National Immunization Advisory Groups have been in consistent follow-up with the global technical body, and then the technical institutions like CDC and the WHO, UNICEF, and all other relevant agencies. Then followed by, we have a development of series of strategies and guidelines prioritizing the vaccine allocation framework, national vaccine deployment plan, and also the health workers guideline. The manuals have been developed. Then of course in the country we have had a comprehensive assessment of cold chain storage capacity, considering any kind of vaccine that we can foresee, because at that moment of time we were not very sure of what kind of vaccine that will be made available to us, or what kind of vaccine that we will have access to. So different level of our healthcare systems, even in the public health, primary healthcare center to district hospitals to regional to central level, we have thoroughly mapped the cold chain storage capacity, be it 2 to 8 or -20 for Moderna, or -80 or 90 for Pfizer. So then we did have a human resource planning and mapping how many vaccinators, because we were eagerly waiting for the vaccine supply. The moment we have vaccine, we wanted to complete the entire population within 3 or 4 days. So we really had to struggle, work on how many human resources do we need, additional human resources to cover, because we are buying the time. Within 3 days if you have to complete, within 7 days if you have to complete, within 10 days, what could be our human resource implications and requirements. So all these number of vaccinators have been mapped by districts, and then depending on the medical council's regulation, who can vaccinate and who cannot vaccinate. So we have also been line listing all those vaccinators as well. The milestone, the cornerstone of our success of vaccination program, I would contribute to the Bhutan vaccine system. It's an online web-based portal system where a real-time data monitoring has been done. So Bhutan vaccine system was developed in-house in Bhutan, and then all the registrations of the vaccine recipient, as well as all the AEFIs and vaccination certificates have been built in. So this is one typical example, one of the successful example that we have rolled out using this Bhutan vaccine system. Then we had several coordination and collaboration meetings with stakeholders, awareness, and then because we have to at least have a support and leadership from different stakeholders, including the local government, media, then development partners, all our national council and parliamentarians, we have been able to negotiate and then do our advocacy and awareness program as well. Then several trainings and capacity building, including TOT and district level cluster trainings have been conducted. All the university students have been trained and then kept as a backup plan for the immunization if you require their support in case if you have to complete the vaccination at given time. Then AEFI was taken very seriously because it was a new vaccine. So different level of training has been done through support from WHO and other relevant stakeholders. Communication and social mobilization, I think we were champion in this, because I have never heard about Prime Minister going live in the Facebook page or in the national television, clarifying the general public on the vaccine hesitancy. So we had from the highest level of the government leadership, where all the awareness advocacy programs have been initiated, and then through our media sensitization and robust awareness program to the lowest level, including the local government and also the religious and other institutions, local government, village health workers have been trained and advocated. Then in terms of AEFI management, we have already, we at the national level and district level, we already have an AEFI committee, but for this matter, we have created a regional AEFI committee, which was quite new for us, in order to provide the timely support to the general public. And also we have deputed specially trained doctors to each and every nook and corner of the country to monitor and support AEFI, not necessarily AEFI, but having doctor in the vaccination post gave a lot of confidence to the general public that in case if there's any reactions, there's somebody to take care. So these are some of the strategies that we have used, and then we did not have major problem in terms of AEFI. In terms of vaccine supply, of course, I will be going in detail later slides. Vaccine supply, we have several bilateral and multilateral donations and support given to Bhutan. And of course, to us last month and before last month, the government has also made some procurements in terms of vaccine supply. Distribution, we were able to distribute the vaccine within 4 days to nook and corner of the country, because we were so urgently waiting for the vaccines arrival. The moment vaccines have been arrived, we have used chopper services, available domestic flights, and all the refrigerated vans were ready. And then we have distributed within 4 days to nook and corner of the country, that we could for the timely rollout. Before the rollout, we did have a mock drill where we have learned several lessons, and then those corrections have been made immediately overnight to all the health centers with the coordinators in the districts. Then we could successfully launch the nationwide rollout within, which was conducted from 27th March to 4th April for the first dose, and from 20th to 26th July for the second dose. Right after the launching, we did have a home-based vaccination services, because we are also looking at human-centric public health service delivery in the country, where those people who have registered in the Bhutan vaccine system, online is web-based system, who have registered as cannot walk because of the various reasons, be the age, because of the age or because of the sickness. We have line listed them through the system, and then we could deliver the vaccine through home base to all the people who have registered, they cannot walk. Then as a plan to target to reach 100% coverage, we did have a last mile strategy implemented, different category of, even in the quarantine facilities, we were facilitating the vaccination, because to reach to each and every Bhutanese or people residing in Bhutan. So we have also strategized separate interventions for a particular category of people. So last mile strategy have been implemented. Basically in the last mile strategy, we have targeted interventions. What kind of people we are, what kind of strategy we want to use. So that whole lot of last mile strategy, we have like a guideline for that to implement. And of course, supportive supervision and monitoring was very robust. The National Drug Regulatory Authority, around 27 officers have been deputed to all the districts to monitor, because they are the oversight agency who look after the issues and then recommended the Ministry of Health. So this in brief, the whole overall process, how we have conducted the vaccination program, because ultimately this will boil down to how much we have spent and what could be the delivery cost, and how we have managed financially in terms of delivering the vaccine. Next, please. Now, quickly run through what are the typical strategies that we have used. Our modality was, we didn't roll out based on the priority population groups. I know most of the countries, because of the vaccine access issues and supply issues, countries are resorting to priority groups, maybe like health worker comes first, comorbid people come second, and then frontline workers and all those kind of prioritization. We did have those kind of strategy, but when we had the adequate vaccine, our strategy was to roll out entire nationwide within 1 week for entire eligible population. No prioritization, no geographical risk profiling, no prioritization among the population group. So our strategy was to roll out within 1 day, within 1 week to entire eligible population. That's how we have implemented for both dose 1 and dose 2 in the country. In terms of eligibility, we didn't restrict to only to the irrespective of the nationality. We have given vaccine to each and everyone who were residing in the country during the time of vaccination. And even today, whoever is in the country and eligible for the vaccine, we provide the COVID-19 vaccination from the health centers. So registration and data management, AEFI management, and then vaccination certificate has been managed through Bhutan vaccine system as I reported. Then those at the high risk areas, because during the rollout, we did have some places got locked down in the pockets. So for them also, we have designed a separate strategy to separate protocol and vaccination strategy to cater to them. So those, even in the lockdown situation, we have provided the vaccination to the general public. Home base, of course, as I reported, those who have registered cannot work, bedridden, we have catered through home base. And as a COVID-19 mitigation strategy, people were not encouraged to crisscross movement of the people were discouraged. And then they were categorized into mega zones and the zones. They were supposed to come to the respective zone. They cannot go to other zone because in view of mitigating the COVID-19 spread or strategy, so we have restricted them to come to their respective mega zones in the urban towns. But in the villages, one village will be doing first day, second village, because we didn't mix up the villages, so that in order to mitigate the risks. We have also an app called Duk Trace app, which is basically to scan for the tracking of COVID-19 disease. So that was mandatory that each and every client was supposed to scan that app. And then in case if there are no phone, some elderly people, we have line listed in a register. AEFI, of course, National Technical Advisory, regional and cluster, and mandatory pre-vaccination screening was it came out as a very strong practice in the country. Before vaccination, thorough screening has been done separate, and we invested a lot of resources, and including human resources and time for pre-screening, basically to avoid coincidental events in terms of COVID-19 vaccine. Next slide, please. With all these strategies, because as of November 2, the latest data, Bhutan's coverage for COVID-19 vaccination stands at 80.2% for entire population, overall population for first dose, and around approximately 77% for the second dose. That is overall all age population in the country. If you consider only 12 years and above, we have the vaccination coverage of around 97%, and then with first dose and second dose is around 93%. If you consider children vaccination, because we have also rolled out Moderna and Pfizer vaccine for our children 12 to 17 years. And then as of 2nd November, we have vaccinated each and everyone in the country who are 12 to 17 years for the first dose, because they are mostly in the schools. And then it's very much easy for us to, because we have been doing HPV vaccination, school-based HPV vaccination. We have been doing TD vaccination in the school-based. So this 12 to 17 years, we have immediately rolled out through school-based. And since our school enrollment is so high, most of our eligible children are in the schools, and very few people are children are outside, out of school, and then they were being facilitated by our local government and then the village health workers from each and every community. So this is in brief the coverage as of November 2nd. Next slide, please. Now coming to vaccine support and vaccine mobilization, as most of us, because it has been broadcast in several media platforms. We did have several vaccines in the country, multiple vaccines in the country. For Covishield and AstraZeneca, we have bilateral partners who actually supported us in terms of vaccine supply. And then as far as mRNA vaccines are concerned, Pfizer and Moderna vaccine, some multilateral partners such as Gavi, COVAX, and then US government has supported us with the mRNA vaccine. Then also government, recently we have procured Moderna and Pfizer vaccines by the government for our children. Then in terms of operational costs, of course, the government's portion in terms of infrastructure, in terms of health workers payment, all these things we have not taken into consideration, but just to operational costs in terms of delivering the vaccine, we had support from development partners from WHO, UNICEF, UNDP, and other partners as well. As well as we have revamped the whole cold chain system in the country thanks to COVID-19 vaccine. Our cold chain system has been really strengthened in terms of capacity as well as in terms of quality as well. So that was actually fully supported by ADB, as well as we also received some support from Japan grant, where we have procured several equipments, including refrigerated vans, including walk-in coolers and refrigerators as well. Next slide, please. Now, when it comes to operational cost, we have, this is not comprehensive data as of now, because we are still compiling the data from different districts. So almost $1 million have been spent as an operational cost for 2 successive campaigns, both for first and second dose. For the first dose, or almost like 0.7 million has been spent, and for the second dose, we have spent around $0.4 million as an operational cost. Basically, those expenditures were under the capacity building training, then vaccine transportation, because we were using the chopper services and other possible transportation mode. So these were some of the cost categories that we have spent. Risk communication and social mobilization, district level training, of course, a huge expenditure has been incurred in the district level COSCA training, printing of guidelines and SOPs and EFI forms, and also the advocacy materials. Then, of course, we had support of vaccine. We had received vaccine support from different countries and multinational agencies as well, but we had to buy the AD syringes and AFI drugs. So some cost has been incurred here as well. Bhutan vaccine system, of course, it has built in-house, but we did have to pay some expenses on this as well. Monitoring, evaluation, and post-vaccination campaigns has also been done. Next slide, please. Final slide. So if you look at the cost, most of our cost, more than around 56% of our cost, both in terms of dose 1 and dose 2, are in the implementation cost rather than startup cost. So these are something that I think it might vary from country to country, but in our context, of course, these are not comprehensive data, but what data as of now, whatever data we have, this is a breakdown for both the doses. Our startup cost were less than the implementation cost, and major chunk of our cost was on the personal travel, because during the vaccination campaign we have around thousands of people moving around to provide the vaccination, because we were running for time, because within 1 week we had to complete the vaccination. So the cost was in such a way that implementation cost was higher than the startup cost. Next, please. For the future, we did have, there was some discussion on integrating COVID-19 vaccine into our routine immunization costing and program. So we have already thought through, and then we are trying to, we have already made a projection, and then it's at the version of submitting to our relevant funding agencies, for example, Bhutan Health Trust Fund, which is by royal charter mandated to finance all the vaccines. So we are trying to negotiate, submit all our requirements to Bhutan Health Trust Fund, and accordingly, they will be able to mobilize our requirements for not necessarily COVID-19 vaccine, but all other vaccines in the country. And then, as we all know that there are recommendations for third dose for all immunocompromised individuals. We might have to roll out, we might have to buy a vaccine for those. Then the booster doses are coming up after 6 months. Boosters have been already recommended. Developed countries are already using booster doses. For us, we are thinking of having booster dose to high-risk groups, at least the priority population groups. For that, we might require some expenses. So for the immediate requirement, we have projected some amount, and then as I reported, we are communicating to relevant agencies for the fund mobilization. Thank you very much. I think this is end of my next slide. Thank you very much. This is end of my slide.
Thank you.
And then I would love to take any questions if there is.
Thank you very much, Dr. Sange, for this excellent presentation, sharing Bhutan experience. In short, Indeed, it seems that different factors have played roles to Bhutan's success, but the very comprehensive, detailed the preparedness within the health system as well as outside the health system, and backed by the excellent coordination across sectors and partners seems to have contributed the main role in Bhutan's success. Thank you very much for sharing this excellent experience. Okay, we have so in the Q&A part, we don't have any question to you, Dr. Sangay. Perhaps the participants can send us the specific details after examining further your presentation. But now that's all in terms of sharing the experience from Southeast Asia region. And I hope you enjoyed learning from these insightful presentations. And I would like to thank my three speakers for your for your willingness and support to make this session successful. Thank you to the audience as well. And now over to Karen.
Thanks a lot, Solomon, and all the presenters for the excellent presentations. So here comes the end of the sessions, and I would like to open up the feedback pool to understand how much you learned from the session. There will be 2 questions. So if the team can open up the feedback pool, that would be great. And we have 2 questions. Mainly on how much you learned from the session. So the first one, after the session, do you have a better understanding of the economic and budgetary implications of COVID-19? You can answer yes, somewhat, or no. And the second question, after the session, do you find the landscaping analysis on COVID-19 vaccination financing in the Southeast Asia region useful? Also, yes, somewhat, or no. So I think that will be a quick questions. Please answer, and if we have enough response, ECHO team can please put up the result.
Corinne, while participants are answering the poll, I see 2 questions in the chat for Mr. Sangay. Perhaps he would like to take those 2 questions. The first one is about how many people or doses can be vaccinated during campaign 1 and 2. And the second question was how many health workers were mobilized without deviating them from essential services. I think that the second question is particularly interesting for the wider audience. Thank you.
Thank you for the question. We did not have much issues in terms of health workers mobilization because our population is very small. And then in terms of health workers, vaccinators, number of vaccinators available in the country, we didn't have much issue. But having said that, in the urban centers, in the larger cities where there are a huge number of population, eligible population, we have mobilized the university students, the final year students from the university. They were trained on vaccination, and then because through our experience, it was not an issue with the vaccination, but with the whole lot of other arrangement, the screening, with the logistic support, we require more health workers. But those people who can vaccinate, health workers who can vaccinate, we have not given them any other responsibilities. For them is to just vaccinate. Other coordination and screening, we have a whole lot of other volunteers. Each vaccination post has around 5 people actually to coordinate and then support the vaccination program. So in that way, we did not have much issue with the HR in terms of mobilizing. Of course, we have mobilized from the university students. In terms of total number of people vaccinated during the campaign, whoever were eligible on that particular week, we have provided the vaccination. But there were some eligible population who were pregnant, and some were breastfeeding, some were sick. And those people who could not come during that week, we have facilitated the vaccination through the health center based approach after the campaign. So that's why even today, those people who were not able to take the vaccine, because especially the travelers who are coming in from abroad, if they are not vaccinated, we are still facilitating them the vaccination in country. Thank you.
Thank you, Dr. Sangay. So we can pull up the poll results. if the participants have further questions, please feel free to put in the chat or Q&A. Okay, so great. So more than, okay, no one has answered no, and more than 70% got the understandings of the economics and budgetary implications, and you find that the landscaping analysis useful. Great, great to hear that. And you will, next slide, and all the materials for this webinar you can look up in the through the emails and also the TechNet 21 forums. And if you have further questions after the sessions, you can also ask in the TechNet 21 forums and Telegram. And thanks very much for the TechNet team for supporting. And you will find the recordings and slides there. Next slide. And the recordings will be in English, French, and Spanish. And the next session will be on 1st of December on the country, regional, and global views on COVID-19 and COVAX data. And you can register through the link. Next. And I think that will be the last slide. I would like to thanks very much again for your participations, and we look forward to seeing you again in the future sessions. And thanks for the translators during the excellent interpretation, and the ECHO team, presenters, and all the colleagues supporting the session. Any questions related to the session and that were not answered will be shared with the technical experts, and the answers will be shared through email. And wish you have a lovely day. Thanks a lot, and bye-bye.
Thank you, everyone. Thank you.
Thank you. Bye-bye.